There we go. Here, wait, Tosh, say hi. It's my dog, Tosh. Are you gonna stay? No, he's not interested in learning about central lines. Hey everybody, welcome. Thank you for joining me tonight for Perfecting Your Craft Week 4. We're gonna be talking central lines today. And just so you guys know, Hannah is asleep. I can't, it's too late for her. Here's a little hand. Oh, you probably can't see it because of the light. Wait, hold on. Wait, hold on. Can you see her? No, you can't. I have her on a little video monitor so I can see that she's asleep. So sweet. Okay, so my beer this week is called Couch Surfer. It's an oatmeal stout. Where is it brewed? I don't see where it's brewed. Otter Creek Brewing Company, but I don't see where that is. But so it's an oatmeal stout. I'm really enjoying these stouts here. So that's gonna be, oh, okay, clinical with the PICC line. So I'm gonna talk about those. Okay, so let me just go ahead and jump right in and let you guys know. I'm gonna put this video on YouTube. I'm gonna edit it up a little bit and then put it on YouTube. And then I'm also gonna put my, oh, I've heard of it. Never tried that beer, but I've heard of it and somebody told me about it. I need to try it though. I need to take a picture with it. So I have my notes here. I will put those online. I am working a lot the next 4 days, so I will try to do that next week. And I probably am going to take a week off from doing the structured Periscope next week because I'm working a lot lately and it's kind of hard to get both of these things done, and I want to make sure these are quality, so it might be a week or so before I have another one. So again, I'm drinking the Couch Surfer and Oatmeal Stout from Otter Creek Brewing Company. Cheers to those of you that are also enjoying a craft beer with me. All right, so let's start talking central lines. And my disclaimer here is that this is for informational purposes only, people. Make sure that you're checking your hospital's policies and procedures and following all that. The percent, 5.4. Cheers to the post-shift bourbon. I'm trying some like different kinds of whiskey and bourbon, which I'm enjoying surprisingly. I'm not too advanced with it yet, but I'm trying the different kinds of whiskey. I like that. So, okay, central lines. So keep in mind, if you're new to this, if you're a student, a brand new nurse, or maybe you've been a nurse for a while and now you're seeing more central lines, these are really confusing, okay? There are a lot of different products, and I feel like more and more are coming out all the time. It seems like they all have a different protocol for how they're used, and how they're inserted, how they're used, how whatever, what you're flushing it with, what they're called, and then evidence changes frequently. Evidence-based practice about what's the best thing, to do to maintain them. So it is really confusing. So don't feel discouraged if this stuff doesn't make sense. It'll take a little while, but it'll make sense eventually. So I'm hoping this can be some groundwork, some baseline, so you can kind of, okay, go in the room and kind of know what to do. So basically, a central line, it is not a peripheral line. So there's a PIV, a peripheral intravenous catheter. So in your hand, sometimes in the foot, in the arm, those are PIVs. This is a CVC, a central venous catheter. So the end of this catheter terminates in the superior vena cava. So the end of it is an SVC. So that's how you know it's a central venous catheter. And I actually pulled up a picture here. Oh, dang it. You might not be able to see. There it is. Okay. I pulled this offline. So if you can see here, it goes into the skin here, and then right here is the superior vena cava. So it's right above this right atrium here. And that's what makes this a central. Okay, so, and I used to think that central venous catheter, it was good because it was going into the superior vena cava because it's a big vein. Well, that's not really the reason why it's ideal that it's there. So it's dumping into the right ventricle, right atrium, where there's this big volume of blood. So instead of something going into this peripheral IV here, and going all the way up here, and then eventually getting into your your atrium, you put it in immediately and it's immediately hemodiluted. It's got all this blood, so this caustic or really bad for you, really bad for you medication is all of a sudden with all this blood. Oh, good. Yeah, if you can make some sort of a chart for new people or people that have been there for a while, it's really helpful. And I'll try to get to questions as they come through, but it'll be kind of challenging. I want to get through this and then maybe we can do a Q&A at the end. Okay, so that's important. So why do people have central venous catheters? Lots of different reasons. One of the main reasons is a really caustic or vasoactive or constrictive or dilutes or the veins. So they're really hard on the veins, so you really don't want it hanging out concentrated in there for very long. You want it diluted immediately. So like TPN, parenteral nutrition, those vasoactive medications, norepinephrine, epinephrine, phenylephrine, all those kind of medications, you want them in this central line to get in there immediately so it's not screwing up your veins and causing phlebitis and irritation and excavation and all that kind of stuff. So that's one of the big reasons. Also like dialysis, maybe someone's on vancomycin for a long period of time, long-term meds, or significant volume resuscitation, like someone is profoundly hypotensive and they need a ton of volume, and it's kind of an emergency situation, the physician may put in a line. So there's also something called a PICC line, which some of you have heard of. It's a peripherally inserted centralized catheter. So instead of it going in the subclavian area or the IJ area or the femoral area, it goes in kind of in the upper arm right here, usually on either side, and it ends in the same spot. It just starts in a different spot. So that's the difference. Now, something that's confusing, I don't know if any of you guys have heard of a midline catheter. It looks exactly the same as a PICC line catheter, exactly identical to a PICC line, but it's cut short. So instead of it starting here and ending here, it ends here. So it is not a central line. The confusing thing is they look on the outside identical. The only way you're going to know the difference is if you look in the documentation from when it was inserted. If it says it terminates in the SVC, if it says it kind of in the doc flow where it ends or how long it is. So if it's like 35 centimeters, that's going to be in the SVC. If it's 15, 20 or something, it's probably terminating up in their axillary region. So I'm sure a lot of hospitals have policies where you label on the outside, but if somebody forgot and you're administering medications through this midline that is not actually central, that can be a big deal. Because at least if you have a peripheral IV and you're inserting something that is going to screw up the vein, you can at least see when it infiltrates. If you have it terminating up here and in one of these deeper vessels, you can't necessarily see it. So it's really important if someone has a PICC line that you know that it terminates in the SVC, especially if you're giving those medications that can really cause some problems. So that's what they are. What we call them, so people will say, we're dropping a line, patient in bed 4 is getting a line. A lot of people will call them a line. They'll call them a CVC or a central line, central venous catheter, or maybe they'll just call it by, that's a good question. What's the point of a midline? That's for patients where you can't get an IV otherwise. Like you can't get one anywhere else, so you'll put in a midline just to have access. Inserting a line like that just to have access should be the last resource, but I'm seeing it more and more frequently. I mean, you get those dialysis patients, those IV drug users, and you cannot get a peripheral line in. That's why they'll insert a midline. So, okay, I talked about all that. Insertion, so they can be inserted multiple places in the ER, right in the room, right at the bedside, up in the critical care units. A lot of times they can be inserted in the OR. Anesthesia can put them in. that kind of stuff. So they can be put in pretty much anywhere. It's a bedside procedure. I know at our facility and in the last one I was at, the nurses assisted the physician, like kind of being part of the sterile procedure and handing them stuff while they're putting it in. And the second that they're done putting it in, that bad boy is the nursing staff's responsibility for the use, the care, the removal. It's all our responsibility after they drop the line. So it's really important that we know the best way, the way that we're supposed to care for them. Oh, what's up? Hi, Canada. Okay. Care and maintenance stuff. So you have to assess. Wait, let me go back to when it's inserted. So when it's inserted, let's say you've got a patient with like 2 or 3 IVs that are going bad and they're barely hanging on, and once you get this central line in, you're going to use that and get rid of these other IVs. You can't just unhook your fluids or whatever it is from these peripheral IVs and hook it to the central line. You need fresh tubing. It's really important. This line terminates in their heart. You do not want to get anything infected in there. So if you're taking these older lines and putting them there, that can potentially cause an infection, especially if you're not doing it like cleaning off the hub and all that kind of stuff. So that's one of the main things that you're gonna, once the physician's done putting it in, you're putting on the sterile dressing, sterile procedure, putting on the dressing, changing out the caps or putting on fresh caps and having fresh lines. So it's really important for when you just have a brand new one. All right, so then every time you go in to care for this patient, you're taking a peek at their dressing, or let's say it's here, or if it's on their subclavian, you're taking a look. You're making sure the dressing is occlusive and it's not half hanging off, because if this thing's hanging off, that means bacteria can get in and they can get a central line associated bloodstream infection, or CLABSI. I don't know if you guys have been hearing people say that a lot. That is one of those big bad words in nursing, because it's an infection that nurses can cause from improper care, or can be caused by improper insertion, but we're the ones that are caring for it and accessing it and cleaning it and all that kind of stuff. So it reflects poorly on us if a patient gets one. So we really have to make sure we're doing all we can to prevent that. So that's why you're always taking a look and making sure that the dressing looks good, the antimicrobial patch that's sitting on the insertion site looks good, and if it's saturated, fully saturated, that you're switching it out. Again, refer to your policies, but typically you're only changing the dressing every 7 days. You don't want to go in and put a new dressing on every day, because every time you pull off a dressing, you're exposing that line, and it's another chance for infection. So if it looks great, you leave it for 7 days, and even if it looks wonderful, at that 7-day mark, it needs to be switched out, cleaned, and put a new one on. So when you're using it, you're going to, again, look at your policies and procedures, but yes, 7 days, yeah. And you think about it, a lot of these patients that are getting these lines that are going straight to their heart are maybe some oncology patients or patients with compromised immune systems. So if you're not cleaning it appropriately, assessing it appropriately, attaching and detaching lines appropriately, we can cause an infection that can kill somebody. It's a big, big deal. So it's a line that's going from the outside straight to their heart. So if you can kind of keep that in mind about how important it is to make sure you're doing it and caring for it the right way. So like at our hospital, we've got, I don't know if you guys have heard of those Kuros caps, the little green caps. I love those things. We have those on ours for, you know, whenever they're not being used. I've got these little green caps on them. They have alcohol on them so that when you pull one off, the line, the end of it's clean. Something to know though, let's say I'm going in to give a med. So that means I got to flush the med, another flush. So I take off my Kuros cap, or I scrub the hub 10 times. I flush I do my flush. Then I go grab my med. I can't just attach it again. I need to clean it between every single time something is touching the end of that. So whatever, oh, swab caps, love it. Yeah, Kuros is the only brand I'm familiar with, but I know there's a couple others. Yeah, they're really convenient for the nurses. So you have to clean it between every time something touches the end of that line and engages it. So you really have to make sure you've got multiple alcohol swabs. So you can't just take off a Kuros cap or a whatever that was, cap, and engage, flush, a new one, and a new one. So that's just something, like, it's kind of a big deal. You have to make sure you're doing that. Another thing is you always want to use on a central line a 10 milliliter syringe. Never flush or give anything with a 3 milliliter syringe. The reason for that is the diameter of the barrel of the 10 milliliter syringe is wider, so there's less force when you're like flushing it than there is with the 3 cc because it's so much smaller. So you can damage the end of the catheter that's, you know, wherever it's ending with when you're using the 3 milliliter, because if you push it, it can mess up the end of it, which would be a huge deal. So never use 3 milliliter syringes. If you're drawing up a small amount of medication, yeah, definitely use a 3 cc to draw it up, but then transfer it into a 10 cc syringe, or at least something with the same barrel size. Another thing too is IV tubing that connects to the central line. So let's say, and some of this stuff, guys, I didn't learn this first go around before I touched a central line. This stuff took a little while for me to learn all this. So something I learned within the last 2 years is the IV tubing. So at my hospital, and I believe a lot of places are the same, where IV tubing, if it's closed and it's attached, let's say I've got an order for 100 milliliters of normal saline an hour. Okay, great. I'm going to go get it, prime it, hook it up, and write on my tubing it's good for 4 days, 96 hours. So I write that on there. And it's good for 4 days if it's a closed connection. But let's say physical therapy wants to get my patient up and they want me to disconnect the thing, which makes sense, less stuff to carry around. Well, I've unattached it. So it's no longer a closed system. So that IV tubing is now only good for 24 hours. Okay? So even if it's just for a second, even if it's just to move the IV pump from one side of the bed to the other, or for whatever reason, this system that was closed is now open, and it is no longer good for 36 hours. It's only good for 24 hours. So keep that in mind. When you're drawing blood, yep, see, I learned this like 2 years ago and didn't know that. But so that's, you know, you live and you learn. You'll just do it different now. Okay, so the next thing is the caps, the white caps or whatever color cap they are. If you're drawing blood out of them, you got to get a new cap. You can't draw labs and leave them and you have to get new caps, because if you think about having the blood drawn out of there, if any of it's sitting in there, that's a great place for bacteria to grow. So you want to make sure you're switching out your caps every time you're drawing blood out of them. And that brings me to my next point. Every time you use it, you need to check for blood return. So let's say you can flush it, but you can't pull blood back. And I also learned this not that long ago. When you can't pull blood back out, that means that, I'm trying to think of a way. So let's say if you can't pull blood back, let's say, so you can push blood through, you can push your saline through, but if you can't pull back, there's like a clot on the end of it. So you're pushing medicine through, and then when you're done, it just closes back and it can't pull the blood out. Yes, a one-way door, one-way valve. So you can't use it until you get rid of that clot, because what if you flush it and you send that clot flying and it goes somewhere and there's a bad outcome because of that. So that's something that I didn't realize until a couple years ago, I think. I can't remember when, but it's like, I didn't know that. I've been using so many that I could flush but not pull back. So make sure you're pulling back to see if there's blood every time. And if there's not, you're following the procedure for that. So for us, I got to put TPA in the line, got to get an order, and then I got to put TPA in the line, and then reassess, and hopefully that gets rid of that clot at the end. So remember, you must get blood return when you're flushing it, okay? And the way to avoid the clots from forming is to flush it every shift. There should be standing orders whenever anybody gets a central line dropped to have flushes every shift according to whatever. Yeah, you want to, make sure you're doing all the little checks. Okay, if I move it this way, if I do this, or if I do this, or whatever, I'm still not getting blood return, that's a problem. So, So flush it every day. And different kinds of central lines will require different kinds of flushes. Most of them do require a heparin flush. Okay, that's a good question. Does your hospital allow us to TPA lines in patients that have had bleeds in their brains? I always obviously you're calling the physician first. They usually say yes because you're only giving enough TPA to sit in that line and then you're pulling it back out. So most of the time, unless it's like they just came in with this fresh bleed, but typically if they just came in with this fresh bleed, they don't have this central line that's been hanging out for a few days that has a clot on it. So I always call, they always say yes. And God forbid it gets into their circulation. It is such a small amount, but that's a great question. You always want to make sure, but you're pulling out all the med that you're putting in, and it's only enough to sit in the line. So you flush it every day or every shift. And if you have a patient has a central line and you notice there are no flushes ordered, that's a problem. You got to put in, maybe you have an order set or something like that where you have routine flushes on all of the lumens. And something else I learned is so I used to think, okay, I'm sending my patient to get a line put in. I want as many lumens as possible. The more lumens, the better. Yay, right? Wrong. The more lumens you have, the more likely it's going to clot. And I didn't realize that. So let's say you have a single lumen catheter. So the diameter of the catheter is this big, okay? But now let's say I've got a double lumen catheter. Well, the diameter is still this big, but now each lumen, their diameter is each this big, okay? And let's say I have a triple lumen. Well, the diameter of the main thing is this big, but this little hole is divided into 3. So if you think the smaller the catheter, if the more lumens you have, the smaller the diameter is of the catheter. So again, more likely to clot. So it's even more important for you to have flushes for those patients, okay? And it makes a lot of sense to me. I just didn't realize that. I kind of put the pieces together like, oh, well, yeah, that does make sense, because I'd send a patient down for a cath, oh, hello, China. I'd send a patient down to go get one, and it'd only be a double lumen. I'm like, why are we doing this? Why aren't you getting a triple lumen? Well, it's because they didn't really need a triple lumen, and it makes sense. You don't want it to clot off and have a problem. So it's really important to make sure that every patient that has, I just learned this too. Yeah, I always want as much access as possible. But if you've got someone that's getting one vasoactive med and that's it, and you're really just getting the line for this one med, you don't need a triple lumen. Sorry. So make sure you're flushing every shift. You're also flushing promptly when you're done when you press pause and you think, let's say you're titrating off of a drip. You're trying to see if you can get rid of your Levofed, and you're going to pause it to see if it's going to last or not. Oh, good. Flushing TID. That's great. And you pause it to see how are we going to do with the titration off. And they start doing great, and you forget. Well, if you leave that there paused and not flushed and clamped, it's much more likely that thing's going to clot off. So it's really important when you are pausing or turning off or whatever, that you're disconnecting the line, flushing it, and clamping it. So, that's really important to do. Otherwise, you're leaving it engaged between the Lure lock. It's engaged and open, and it can easily clot off. So it's really important to make sure you're doing that. And the other thing, the last thing I want to talk about, yeah, that's a lot of places, or not a lot, I can't speak for it, but I know people that like to do the KVO because it keeps the line open and you're not going to clot off. I really like that because then I can just piggyback stuff on, but you do have to replace the lines, but still. So removal. Removal is something that nurses do as well. Does anyone out there know what the really, really important thing you need to do is when you remove a central line? Anybody? I don't want to give it away. This is so important. The tip, well, sometimes you may want to culture it. Yes. Cough, hold pressure, no idea. Lay flat. I knew you'd get it. I knew only in the ICU would get it. You have to lay them flat. Does anyone know why you have to lay them flat? And why that's a big, huge deal? Anybody? I'll take another sip. I'll give you guys a second. Yes, air embolus. Yes. Okay. Okay, lay flat, air embolism. Perfect. So here's the deal. You lay them flat, and then you pull out the line. You go through your whole policy. You do the way you're supposed to do it. But if you just pull it out, having them sitting up in a chair, pulling out their IJ, you can cause an air embolism and you can kill a patient. You can kill somebody by not laying them flat, guys. This is so serious. I was reading an article on CNN like a year or two ago, and it was like the 10 biggest medical mistakes, and it's like cutting off the left leg, and the right leg was supposed to get cut off, like all these horrible medical things. And it showed one. It was this 18 or 20 something year old guy who was in the hospital for, I don't know what, some infection, and ended up getting a central line. He was ready to go, getting discharged. The nurse took out his central line with him sitting up in the bed. He coded a little bit later, and he died. Let that sink in. This is one of the, never should ever happen things, but it does. Yeah, and it can still happen. You can still throw an embolism if they're laying flat. You still can, but it is much more highly likely if they're sitting up for that to happen. But yeah, even if you're doing it perfectly, it could. It's unlikely that it could happen, but if they're sitting up, the likelihood goes way up. And I believe if you think they got an air embolism, you sit them on the left side, lay them on their left side to trap that air in the right atrium or right ventricle, right atrium, on the right side of the heart. See, this is one of the, yes, okay, I was pretty sure it was the left side. Thanks, guys. All those other critical care nurses out there, thank you. And this is so crazy important because it's stuff that can really legitimately kill somebody, ruin that family's life, and screw up your career kind of thing. So you want to make sure that you're following your procedure to a T, and it probably just has one little line that says, lay patient flat. Never let them sit up in a chair. Even if they don't want to get up from the chair and lay down, you must. You absolutely must. While it might be unlikely it would happen, how crazy awful would that be if it did? And then And if you're a new nurse and on orientation, they say, oh, it doesn't matter. It doesn't matter. We take them out with them sitting up all the time. Hey. And they say, this is the way we've always done it. I don't care. How long do you lay them flat? I believe it's just when you're pulling it out. I would have to see if I went to work tomorrow and had to pull one out. I'd have to pull the policy because I can't remember the exact steps, but I know it says on our policy somewhere. But this, great question. This brings me to my next point, is you really have to be aware of your policies and procedures at your hospital about the most accurate way to do things. Because, like, let's say I'm orienting on a new unit and they say, and a lot of our patients have central lines, and before they get discharged, we take them all out, but they always are sitting up, and we don't make them, don't make them lay down. And they say, oh, that's just the way we've always done it. That's like nails on a chalkboard sentence for me. Medicine and nursing changes constantly. So if someone was trained 5, 6, 7 years ago on how to remove central lines, anything that's not the best evidence-based practice of the way to do it today. You always have to look at your policies and your procedures and have that guide your practice, not that's the way we've always done it kind of situation. You can really get yourself screwed over by that kind of stuff. So I can't tell you how important it is. This stuff changes. You don't want to bank off of what someone said that got trained 20 years ago about how to do it. This stuff changes all the time. It's just the pressure change from that being pulled out and it being like in that location. And look it up. There are patients that die from this, and it's solely from the nurse pulling it out. So it's really important with your central lines that they're laying flat. And I think when I was looking up stuff, you know, not everybody can lay flat. The pulse is crying. Oh, I'm sorry. Family was freaking out that I laid patient back. Sometimes you got to educate people. Like, okay, it is essential that I lay them flat for this procedure and set them back up because the risk of this air embolism outweighs the discomfort or whatever. So told them why and they were okay. Yeah, a lot of times it's just education. People don't understand and maybe, oh, he can't lay flat. Well, why can't he lay flat? Is it a really good reason why he can't lay flat, or is it really uncomfortable for him? Like, okay, you can be uncomfortable for a couple minutes while I safely pull out this line and then I'll set you back up. But, I mean, sometimes there are patients that cannot lay flat for whatever reason, like a very legit medical reason. When I was looking up stuff for this, I believe it said to at least push it back at least 15 degrees from wherever their normal is or something like that. But the more flat you can get, the lesser the risk of this embolism is, okay? So that's my spiel about central lines. I hope that was helpful. Does anyone have any questions? And I hope I didn't terrify anybody, but it's a big deal. We have a lot of power as nurses we have to take care of these appropriately because a patient can get an infection and it can kill them, or if we can pull it out the wrong way and it can kill them too. These are a big deal, guys. But they're also very confusing, and when in doubt, look at your hospital's policies and procedure. A lot of these will have like a central line, and then it'll have a bunch of checklists. It'll say, this is how you help a physician put it in, this is how you take care of it, this is how you remove it, this is how you do blah, 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 blah. Does anyone, I'm going to give you guys some time, if anyone has any questions, I'll do my best to answer them. Oh yeah, hey, me too. I didn't learn a lot. I've been a nurse 6 years. I didn't learn some of this stuff till 2 years ago. So I'm trying to help y'all out that are going through this. Yes, you do. You apply occlusive dressing. Yeah, usually. That's in all the policies I've seen. Because you want to seal off that connection to their heart. And usually the policy will say hold pressure for a certain time. Oh, see, I don't deal with med ports very often, so I cannot answer that question. It said, do I access and de-access med ports weekly? I don't access them enough to be able to answer that question. The last time I probably had one was like 6 months ago. Good. Yeah, see, I thought I understood it all. Oh, yeah, you like that go time braid, y'all? Yeah. Oh, and I forgot. So I don't know if a lot of you guys knew this. I am now working for nursing. Okay, so wait, lay flat. So lay flat to take the line out. If you think they've had an air embolism, which is like they're coding and dying kind of thing, you lay them on their left side. You don't need to lay them on the left side unless you think this has occurred. Okay? Unless your policy says otherwise. That always supersedes what I say. John, oh, it's T. Gray. Oh, good. I'm so glad. John, come say hi. How did you guys see our Periscope? We had a Periscope the other night. Why the left side? Oh, the left side, you want to lay them, if you think they've had an air embolism, you lay them on the left side to trap that air in the right ventricle or atrium so it doesn't go into the pulmonary circulation and then get sent wherever, cause a PE, okay? So you want to trap it in the right side of the heart so it's not proceeding like the rest of the blood flow into the pulmonary circulation. Oh, okay, so oncology floor. How often have you learned to change port needles and dressings? Okay, I'll go back. Yeah, that's kind of like what I was saying before. I don't access them that often. Honestly, for my unit, we don't get them very often, so it is a high-risk, low-frequency procedure. So I actually, every time I've done that, I've had to look up the policy, and I've actually called the oncology floor because I don't know how to access it. Someone else always comes and does it for us and de-accesses it, so I'm sorry, I can't answer that question. No problem. It's my pleasure. What else? I feel like, oh yeah, so guys, I work now for nursing, nrsng.com. I love it. basically I'm doing this, but in a little bit more of a professional setting where it's like I've got an actual PowerPoint, I've got a microphone, I've got a little pad thing. So actually I'm starting to make these kinds of videos, but just within that website. So I'm really excited about it kind of taking off. I think that, I mean, that sounds appropriate, and I would just, when you go to work next time, just double check your policy and procedure, make sure you see that written. And you know what you can do, guys? Okay, I wanted to show you guys this. So you guys might know I'm a member of the ANCC, the American Association of Critical Care Nurses. And every, specialty has their own, sorry, I'm logging back into my computer, has their own professional development or professional organization. So if I have questions about this stuff, I go to my professional organization and I search their resources. So that's what I did. And I want to show you how I did that real quick. Let's see. I know a lot of you are critical care nurses, okay, so this is the main website. So, and this is me logged in. So I just went here to my search box, central line, boom. And then I get all of this evidence-based practice and all of these latest articles about central line care and all evidence-based review and discussion points. Evaluation of cursor line method for measuring blah, blah, blah. The scrub club, like cleaning stuff, like decreasing rates of central catheter infections. So if you're curious about what's the latest thing, sorry, let me get this back. So if you're curious about what's the best thing, like for the person that was asking like oncology stuff, like I don't know oncology stuff, I'm sorry. But I'm more so the critical care thing. So if someone has a question for me, so the website is aacn.org, but you have to be a member to have access to the database of all of their articles. Yeah, thank you, aancc.org. So, and then I could do that with anything else. Like I'm a member of the AANN, the neuroscience nurses as well, and I can, okay, what is the, non-invasive cardiac monitoring? What's the latest thing? Yes, they do. Yeah, that's usually a policy, is a saline flush followed by heparin. But there's like one or two devices that don't require heparin, and I don't know them off the top of my head. But that's, so if you're curious about what the best way to do something is, most of the time your policies reflect that, because policies should be reviewed on a regular basis, like to make sure whatever they're telling you to do reflects the latest evidence, because you never want to do anything that's not supported by evidence and proven that this is the best way to do things. And it doesn't, I used to think you just did research for medicine, but you actually, if you ever want to join your professional organization, you do that individually usually. But a lot of hospitals are reimbursed for it because it's developing your professionalism and, that kind of stuff. So I'm a member of the American Nurses Association and the American Association of Critical Care Nurses. And I'm a member of the American Association of Neuroscience Nurses. And all I do is I pay a due every year and I get access to all their journals. And they actually mail journals to me monthly, like print ones, and then I have access to all the online ones. They all have a fee, but my hospital reimburses it. So I'm a member of all these. I have to pay it up front and then the hospital reimburses me back. But it's well worth it, especially when I wanted to find out like what the latest thing I'm supposed to do is. So that is my spiel, because everything you do should be backed up by evidence. And if your policy is not reflecting the latest evidence, then you as a nurse, you're more than capable of, hey, printing off the latest thing. Hey, this is what our policy says. This is what the latest evidence says. Why the heck are we still doing this? And then that's how change occurs. You are a bedside nurse and autonomous, and you can start that change. So that's my spiel. Did I want to give anyone have any questions about journals or central lines and stuff? And stay tuned. The next couple of months I'm going to be doing these, but then I'm also going to have some coming out with nursing, nrsng.com. They're going to be a little more polished, a little more professional, but I feel like people learn a lot really well like this, not necessarily like going through a PowerPoint. So I'm really excited that I'm starting to do that with that team. You know, a couple other, like an ED nurse, another neuro ICU nurse, myself, CRNA, we're all together doing that. Oh, good, I'm glad. Yeah, if you can wrap your head around this, then, you know, I did not know this stuff in nursing school. Just so y'all know, all you students out there, I didn't learn this stuff. Like, this comprehensive thing of stuff I'm telling you right now, I really didn't have my head around this until like a year ago. Totally. And I was taking out central lines of people sitting up because I didn't know. And our unit said, oh, we do it like this. So it's really important to know your policies, know your procedures, and then just, you know, learn as much as you can so you're doing it the right way. I know. Hey, here's a central line. You go deal with it and you don't know what you're doing. So I'm really hoping that I can provide some information so you guys are way ahead of the curve if you're figuring this stuff out in nursing school. I bet if you talk to a lot of nurses out there, and honestly, I went to a meeting about like a vascular access team, and most of the unit was, or most of the people in there were all, you know, very experienced nurses, and we were all confused about the different lines, the different options, what we have to do. Yeah, never, ever remove while they're sitting up. Always laying flat, laying flat. So it'll be on YouTube if you want to catch up with the points I had already made. So does anyone have any questions out there for me? You will do wonderful, especially if you're looking up this stuff outside of school. Yay, thank you guys. I'll give you guys just a little more time, you know, if anyone has anything else. And thank you to all of you guys for tuning in. I really appreciate people tuning in and hanging out with me. Cheers. Thanks. Any questions? Anybody? I'll give you guys a little bit more time if there's some more questions. I don't want to cut it off. I will post notes. I will post this video on YouTube and on my blog. But like I said, it's probably going to be later next week that I do that, just because I'm doing a lot of work the next 4 days, and I don't think I'm going to have time to get to it. Okay, so yeah, it's a great question. So then ones I'm working on are lab values, and it's great stuff. Oh, thank you. May. Those I'm hoping that stuff will be available in May. But if you stay tuned to my social media stuff, I will definitely make a big obnoxious deal when that stuff is available. So you won't miss it if you follow me on Twitter, if you follow me on Facebook. A malfunctioning valve caused a lack of... Oh, I mean, so the question for people that may have not seen it, could a malfunctioning heart valve be a reason for lack of blood flow, like when you're checking for blood return? That would make a lot of sense to me. I think that would be very patient scenario specific. So actually, that's something that I would probably, when the physician's rounding, like, hey, look, I'm not getting much blood return, but I know their valve is messed up and they know the specifics. So I would actually ask the physician on rounding, because that seems very specific, and I would think they would have to be pretty compromised to affect, because when you pull back, you're not pulling back a ton of blood. You should be able to pull back a little bit of blood, even if they've got a crappy valve. But I could see that would make sense if it impaired it, but I don't know if it could impair it to that degree. That makes sense. So sorry, that's not really a definitive answer. No, I didn't. I went into critical care. When did I do that? Like 4 years ago. You know, actually, I take that back. After I became a nurse for 2 years into it, I was like, there was all this stuff, like this central line stuff, like calling a doctor, like all this stuff that I'm like, why didn't anybody tell me this in school? Or why didn't anybody tell me this stuff earlier? Why did I learn all these really essential things on the fly? So when I kind of was getting my head around being a nurse after the first 2 years, I was kind of taking a mental note of those kind of things. And then I had an idea I wanted to write a book going into critical care, but I was like, you know what? I want to get my head around critical care first before I think about anything like that. So it was another 2 years. And then I started the blog, and then I started getting all the same questions over and over and over again. And I was like, you know what? I didn't even think about really writing a for real book. I wanted to be like, here, this is all of my stuff that I would tell every new nurse. This is all the stuff I wish I knew. Here you go. Read this. Let me know if you have questions. And then I was only going to make it an ebook. And then somebody showed me how to do on-demand printing, so I was like, oh, I'll just get it printed, which was really cool. And then over 10,000 copies later, here we are, because everybody else is having this experience too. So it wasn't like I went into nursing knowing I wanted to write by any means. Just kind of followed after. Thank you. I'm so glad. I don't know if you guys know this, but I'm gonna do a second edition. I know there's some errors in it. It's got some, grammatical stuff. Oh, good. Oh, first code blue. Wait till you get to chapter 8. I can't read that without crying. So you can get a copy on Amazon. Just search Katie Kleber or Becoming Nursey. So nurse with a Y at the end of it. It's on Amazon. I made it pretty cheap and affordable because I wanted people that were struggling financially in nursing school to be able to afford it. And so yeah, and Kindle, I think the price is like $7.99 or something. I don't know. And Amazon marks it down too. But what was I gonna say? I was gonna say something and I forgot. I don't know what I was gonna say. But I'm glad you guys like it. This is what I was gonna say. So the American Nurses Association. So you know how I listed my 3, yes, and if you want to write a book, email me and I'll tell you how to get it published. But the ANA, one of the biggest nursing professional organization in the country, is publishing a 2nd edition of Becoming Nursey. I had no idea that would ever happen, but they really liked the book and they felt like it was really valuable, and a lot of people have. So they're gonna help me edit it, get it looking a little bit more professional, because you guys probably noticed there's some errors in it that drive me insane. But correcting those errors is very, very complicated. It's not like I can just upload a new PDF and it's fine. It takes a lot of time. So what they're going to do is help me republish it, and it'll have the American Nurses Association on the cover, which is crazy to me. And then I told them my goal is to make it required reading in nursing school for every nursing student to just have to read it, just so they can kind of get their mind around what it really is going to be like when they walk into their first day. Yeah, neuro. So we'll see, because I have it on Amazon and I can promote it all I want, but the ANA, they have this very credible, one of the most credible organizations in the country as far as nurses go. So I'm hoping I can get it into nursing schools as maybe a professionalism class or something like that, where it's required reading. Because actually I've had some schools call me and tell me that they're making it required reading, which was I had no idea this was going to happen. I just wanted to help out you guys that kept emailing me questions, and it's getting in nursing schools. How cool is that? So I'm still geeking out about it, and I signed the contract a month ago. So I'm hoping by the end of the year that is going to be out on shelves. I do have another book there. So they were really pumped about Becoming Nursey. So I'm writing 2 books for them in addition to this Becoming Nursey. So I'm going to have 3 books out this year. So 2 more. One of them is going to be out on Nurses Week, May 6th. And then another one is a Becoming Nursey Part 2, and that's going to be available later in the year. I'm just not sure exactly when. It's kind of kicking my butt writing these things. But hey, people, you do what you got to do, right? So the other one is going to be kind of the next steps of nursing. So I felt once I had my head around being a nurse on my unit, it was okay, what's next? What's professional development? What's evidence-based practice? What are my options as far as grad school goes? What are my options as far how do I be a good preceptor? How do I be a good charge nurse? So I have a book about that kind of stuff, and that's going to come out later in the year. So that's 2016. I think I need to slow down a little. I'm getting tired. So thank you guys. If anyone had any questions, go ahead and toss those bad boys up now. Otherwise, I'll let you guys go. And we'll get this up on YouTube soon. And oh, and I don't know if you guys saw, me and John did a little Periscope yesterday, and I think we're gonna do another one next week. I kind of like the informal, us just hanging out, asking each other questions, and getting to know you guys, getting to know us better, and just kind of fun. Thanks so much. I'm glad you guys tuned in. So I'll just hang out until like the viewers kind of drop a little bit more, and just to see if anyone else had any questions. Have a good night, guys. Thanks for joining. Throw up questions if you have any. I'll hang out just a little bit. All right. I guess I'll go ahead and sign off. Let me pull it up. Well, thank you so much. Oh, wait. I'm going to link my clinical. Oh, thank you so much. And then if you wanted, I'm about to start nursing school. Any advice? Yeah. Check out my book. I have some advice for nursing school. Check out my blog. I have a bunch of stuff for nursing students. And this website I just started working for, I'm loving their resources, and so wish I had those in nursing school, because it explained things in such a concise way. Is nrsng.com. I really like that. I'm a content editor, and I'm making blog posts and course material for them, and just, it's so valuable. It's great supplemental information. So check out your resources, stay organized. And I would look around online for just some very specific tips. I could go on and on, but I wrote a book specifically for that. So I want you to check it out, Becoming Nursey. You can get a free chapter on Amazon, I think. So yeah. Oh, good. Yeah, check it out. Let me know what you think. Put up a review. Even if you don't like it, I would love to hear that, because I'm making this new edition. So if there's something you felt was lacking, or like you wanted but you didn't get, please let me know so I can consider that when I'm doing the next one. But I think you will find it valuable. I really hope so. All right. Well, you guys all have a wonderful night. Thank you so much for joining me. And I will keep you updated on the next one. I'm not sure when I'm going to do the next one. Because I kind of have to take a week off from doing this, because I'm doing all those videos for nrsng.com. So I want to make sure I'm not spreading myself way too thin. What's up, Jessica? I just saw you joined. All right, you guys, sorry, I'm going to have to go ahead and get off here because I am exhausted. But you can go ahead and check out the replay for the next 24 hours, and then I'll have this on YouTube next week. So, okay? All right, guys, have a wonderful night.